You know, it's amazing when you think about it. Beneath the surface of our everyday health, there's this whole hidden world going on inside our blood.
Absolutely. It's incredibly intricate.
And how our blood clots, or sometimes, well, doesn't clot,
Mm-hmm.
that can be such a huge factor in our overall well-being. Understanding it feels like it could be a real game changer.
It really can. And today, we're going to plunge into a really critical part of that. Anticoagulant therapy. We'll be using chapters from Rutherford's vascular surgery and endovascular therapy as our main guide. It's a fantastic resource.
Right. Think of this as like the fast track to understanding these really vital meds. Our mission today is basically to demystify anticoagulants, how they actually work, what the different kinds are, and what influences the decisions doctors make about them.
Yeah, it's definitely complex stuff, no doubt about it. But don't worry, we're planning to break it down into more manageable pieces. We'll pull out the really key insights so you can get a good handle on the basics without getting totally overwhelmed.
Okay, sounds good. Let's just dive straight in then. To really get why someone might need an anticoagulant, we probably need to start with the basics, right? Thrombosis itself, clot formation.
Exactly.
And I gather not all clots are the same.
Not at all. It's crucial to differentiate between arterial thrombi and venous thrombi. They're quite different beasts.
Okay, so arterial ones first.
Right. Arterial thrombi, these are the culprits behind a lot of heart attacks, ischemic strokes, even limb gangrene sometimes. They're mostly made of platelets.
Platelets, the little sticky cells.
Precisely those. They get activated often when there's a disruption, like a crack in an atherosclerotic plaque, that fatty buildup inside an artery. That rupture exposes stuff that just makes platelets go wild, clumping together.
So they form this platelet-rich plug that blocks the artery, like a sudden roadblock?
That's a great analogy, yeah. Now, a venous thrombi,
Also,
but they're different.
how so?
Well, they often form not because of direct damage like a plaque rupture, but more due to stasis, sluggish blood flow.
Ah, okay, like in the veins of the legs.
Exactly. Especially in the little pockets behind valve cusps in the deep veins, often starting in the calf, or sometimes in the muscular sinuses there too. This slow flow, it reduces oxygen to the vein lining.
The endothelium.
Right, the endothelial cells,
Yeah.
and that activates them. They then attract certain white blood cells and these tiny particles carrying something called tissue factor.
And that kicks off the clotting cascade.
It does. And interestingly, our own immune system gets involved too. Activated white blood cells can release these things called neutrophil extracellular traps, nets, which are like sticky webs of DNA and proteins.
Wow, like a net to catch things.
Kind of, yeah. They trap platelets, help activation. And because the blood flow is slow, the natural clot-clearing mechanisms don't work as well. So it all builds up locally. It's mainly fibrin, that mesh-like protein trapping red blood cells.
Got it. So arterial is more platelet-driven, plaque rupture. Venous is more fibrin, stasis, inflammation. Okay, that makes sense. So how do antithrombotic drugs fit in, generally speaking?
Well, they target different parts of this process. You've got antiplatelet drugs, which, as the name suggests, target platelet activity, mostly for those arterial clots.
Like aspirin.
Like aspirin or clopidogrel, yeah. Then you have the anticoagulants, which interfere with the coagulation cascade itself, the process that makes fibrin. These are key for venous thromboembolism, or VTE.
Which includes DVT and PE.
Right. Deep vein thrombosis and pulmonary embolism.
Exactly. And finally, there are thrombolytics, the clot busters. They actually break down existing fibrin, used more in emergencies. But today, like we said, we're focusing squarely on the anticoagulants.
Right, the anticoagulants. And I know there are different ways to get them: injections, IV drips, pills. Let's start with the ones that aren't pills. The parenteral ones. Heparin is the classic one, isn't it?
It really is. Heparin's a natural substance, technically. It's a complex sugar molecule, a sulfated polysaccharide, mostly derived from pig intestines these days, actually.
Huh, okay. And how does it work? It's magic. Its main trick is boosting a natural protein in our blood called antithrombin. Think of antithrombin as our body's own brake on clotting. Heparin makes antithrombin work much, much faster, like hundreds or thousands of times faster at inhibiting key clotting enzymes, mainly thrombin, which is also called factor Ia, and factor Zal.
So it turbocharges our natural defenses against clots. Is there a specific part of the heparin molecule that does this? I feel like I read something about that.
Yes, absolutely. About a third of heparin molecules have a unique sequence of 5 sugar units of pentasaccharide. This sequence is what binds to antithrombin. That binding changes antithrombin's shape, making it way better at grabbing and inhibiting factor Za.
Okay, so that's for factor Za. What about thrombin?
Inhibiting thrombin is a bit different. Heparin needs to act like a bridge. It has to bind to both antithrombin and thrombin at the same time to form an inactive complex. And
Yeah.
for that bridge to work, the heparin chain needs to be long enough, at least 18 sugar units.
Ah, so size matters here.
It does. Standard heparin, what we call unfractionated heparin, or UFH, has molecules of various sizes. But on average, they're pretty big, around 15,000 molecular weight. Most chains are long enough to do this bridging. That's why UFH inhibits both factor Sega and thrombin pretty effectively, roughly equally.
Interesting. Okay, so how do we actually give heparin pharmacology-wise?
Right. You can't take it as a pill, doesn't absorb well, so it's parenteral. For preventing clots, prophylaxis, it's usually a subcutaneous injection just under the skin,
Like in the belly?
often, yeah,
Mhm.
or the thigh. For treating an existing clot, though, it's usually given as a continuous IV infusion. You could use subcutaneous for treatment, but you need much higher doses to get enough absorbed.
And I heard that how long it lasts depends on the dose.
That's a key point, yes. Heparin binds to the lining of blood vessels, the endothelium, and also to macrophages and plasma proteins. At low doses, this binding mops it up quickly, so the half-life is short. But as you give higher doses, these binding sites get saturated.
So it sticks around longer.
Exactly. The clearance becomes dose-dependent, and the half-life gets longer, maybe 30 to 60 minutes, sometimes more. It's mostly broken down outside the kidneys.
Which sounds like it could make the response a bit unpredictable.
Very unpredictable. That binding to other plasma proteins besides antithrombin varies a lot between people, especially sick people. So the same dose can have a very different anticoagulant effect from one person to the next.
Which is why monitoring is so important for treatment doses.
Absolutely critical. Too little, the clot gets worse. Too much, you risk serious bleeding. You really need to watch it closely.
And what's this heparin rebound thing?
Yes. That can happen sometimes, especially after surgery where heparin was used and then reversed with protamine. It seems heparin that was bound to those other proteins can slowly leak back into the circulation after the free heparin has been neutralized by protamine.
Leading to unexpected bleeding later.
It can, yeah. If it's suspected, you might need to give more protamine.
Okay. So how do doctors monitor heparin's effect? What tests do they use?
There are a few ways. For very high doses, like during heart surgery or angioplasty, they might use the activated clotting time, or ACT. It's less sensitive, but can be done right at the bedside.
Quick results?
Right. But for standard therapeutic heparin infusions, the most common test is the activated partial thromboplastin time, the APTT. That's a lab blood test.
And there's a target range for the APTT?
Yes, although the exact target can vary a bit depending on the lab and the reagents they use.
Oh.
Increasingly, though, labs are moving towards measuring antifactor Isa levels directly. The target range there is usually 0.3 to 0.7 units per milliliter for therapeutic heparin.
Okay. And dosing-wise, you mentioned prevention versus treatment.
Big difference. For prophylaxis, preventing clots, it's typically fixed low doses subcutaneously, maybe 5,000 units 2 or 3 times a day. And with those low doses, you generally don't need routine monitoring.
But for treatment?
For treatment, monitoring is essential. Doctors often use weight-based protocols, or nomograms, to figure out the starting infusion rate and how to adjust it based on the APTT or anti-Zaxa results to get the patient into that therapeutic range safely and quickly.
Makes sense. So heparin's been around a long time. It works, but it sounds like it has some definite drawbacks. What are the other limitations or downsides?
Well, besides the unpredictable response and dose-dependent clearance we talked about, it doesn't work quite as well right near platelet-rich clots. Platelets release something called platelet factor 4, or PF4, which can actually neutralize heparin locally.
Huh, interesting.
And it also struggles a bit against factor Siza when it's already bound up in what's called the prothrombinase complex, and against thrombin that's already bound to fibrin within an existing clot. So it's not perfect at shutting everything down.
And side effects. Bleeding is the obvious one, I guess.
Bleeding is always the main risk with any anticoagulant, yes. The risk goes up with higher heparin doses, if the patient's also on antiplatelet drugs, or if they've had recent surgery or trauma.
Is there an antidote if major bleeding happens?
Yes, thankfully. Protamine sulfate. It binds very tightly to heparin, inactivating it. The usual dose is about 1 milligram of protamine for every 100 units of heparin estimated to be circulating. You have to give it slowly intravenously, though, because it can occasionally cause allergic-type reactions or low blood pressure if given too fast.
Okay. And then there's this other serious complication, heparin-induced thrombocytopenia, HIT.
Ah, yes, HIT. That's a really important one. It's an immune reaction. Some people develop antibodies, usually IgG antibodies, against a complex formed between heparin and that platelet factor 4 protein we just mentioned, PF4.
So the body attacks the heparin PF4 complex.
Exactly. But the problem is, these antibodies don't just clear the complex. They also bind to receptors on the surface of other platelets, causing them to activate.
Activate platelets, but isn't heparin supposed to stop clotting?
That's the terrible paradox of HIT. This antibody-mediated platelet activation leads to the release of prothrombotic microparticles and actually causes clot formation. It's heparin-induced thrombocytopenia and thrombosis.
Wow, so the drug causes the very thing it's meant to prevent. That's scary.
It is. The main sign is a drop in platelet count, typically starting 5 to 14 days after heparin is initiated, though it can be much faster if they've had heparin recently. Even a 50% drop from baseline should make you suspicious.
Who's most at risk?
It's seen more often after surgery, especially major surgeries, and it seems to be slightly more common in women. It can cause both venous clots, like DVT and PE, which are more common, and arterial clots, like stroke or limb ischemia.
How do you diagnose it and what do you do?
Diagnosis involves blood tests looking for those HIT antibodies. There are screening tests, like ELISAs, which are sensitive but not perfectly specific. The gold standard confirming test is often the serotonin release assay, or SRA, which checks if the patient's serum actually activates platelets in the presence of heparin.
And if HIT is suspected or confirmed?
First thing, stop all forms of heparin immediately, even tiny amounts in IV line flushes. Second, you need to start a different type of anticoagulant, one that doesn't rely on antithrombin or cross-react.
Like what?
Options include parenteral direct thrombin inhibitors, like Argatroban or Bivalirudin, or maybe Fondaparinux, which we'll get to. Sometimes certain direct oral anticoagulants. Critically, you should avoid starting warfarin right away in acute HIT.
Why is that?
Because warfarin initially drops protein C levels faster than some clotting factors, which can temporarily make things more prothrombotic, potentially lead to nasty complications like skin necrosis or venous limb gangrene in the context of HIT. You also generally avoid platelet transfusions unless there's life-threatening bleeding, as they could theoretically fuel the fire.
Okay, that's a lot to take in about heparin and HIT. Let's shift now to its relative low molecular weight heparin, or LMWH. How is that different?
Right, LMWH. It's basically made by chopping up standard heparin chains into smaller pieces. Average molecular weight is around 5,000 compared to 15,000 for UFH. It was developed specifically to overcome some of heparin's limitations.
And what are the key advantages?
Well, it still works by activating antithrombin, but because the chains are shorter, a larger proportion of them are too short to do that bridging thing needed to inhibit thrombin effectively.
Ah, so they mostly just boost the inhibition of factor ZAG.
Exactly. You still have that pentasaccharide sequence to bind antithrombin and change its shape for potent factor ZAG inhibition, but less thrombin inhibition. So the ratio of anti-ZAG to anti-thyco activity is much higher, maybe 2.1 to 4.1 compared to 1.1 for UFH.
And what does that difference mean practically?
It means a much more predictable anticoagulant response. LMWHs bind much less to those endothelial cells and plasma proteins that make UFH so variable.
Okay, so better predictability. How about giving it and how it behaves? Pharmacology?
Usually given subcutaneously, like heparin prophylaxis, but its bioavailability after injection is way better, around 90%. Compared to maybe 30% for subcutaneous UFH treatment doses.
Wow, big difference.
Yeah, and it has a longer half-life, typically 4 to 6 hours, again because of less non-specific binding. This allows for once or twice daily dosing, which is much more convenient.
And clearance.
It's cleared primarily by the kidneys. This is important. Unlike UFH, LMWH can accumulate in patients with significant renal insufficiency, so doses often need adjustment or careful monitoring in those cases.
So more predictable, longer lasting. Does that mean less monitoring is needed?
Generally, yes, that's a major advantage. For most patients and most indications, routine coagulation monitoring like the APTT isn't necessary with LMWH.
But sometimes you might check levels.
You might, usually by measuring anti-factor ZAGA levels. Situations where monitoring could be considered include severe renal insufficiency, extremes of body weight, obesity or very low weight, during pregnancy or maybe in some other high-risk settings, just to be sure the dose is right.
And the target anti-AGA levels are different from UFH.
Yes. For treatment doses, the peak level, usually checked 3 or 4 hours after a subcutaneous dose, might target 0.5 to 1.2 units ml, depending if it's once or twice daily dosing. For prophylaxis, the target is lower, maybe 0.2 to 0.5 units ml.
Okay. And dosing is usually weight-based for treatment.
Yes. For treatment of VTE, it's typically weight-based, given either once or twice daily, depending on the specific LMWH product. For prophylaxis, it's often a fixed dose once daily.
What about side effects compared to heparin? Bleeding, HIT.
Bleeding is still the main risk, of course. Some evidence suggests the risk of major bleeding might be slightly lower with LMWH compared to UFH, but it's still significant.
Yeah.
The risk of HID is definitely lower with LMWH, maybe tenfold lower.
But it can still happen.
It can, yes. And importantly, there's high cross-reactivity. So if a patient develops HIT from UFH, you generally should not switch them to LMWH because the HIT antibodies will likely react with it too. Osteoporosis risk also seems lower with long-term LMWH use compared to UFH.
And if bleeding occurs in LMWH, can protamine reverse it?
Yes, protamine can be used, but is less effective than for UFH. It fully reverses the antithrombin, anti-HIA activity, but only partially reverses the anti-factor AZA activity, maybe 50–60%, because protamine works better on the longer chains, and LMWH has more shorter chains.
Got it. Okay, next up parenterally is Fondaparinux. Sounds synthetic.
It is. Fondaparinux is a synthetic version of just that crucial pentasaccharide sequence found in heparin and LMWH. It's very small molecular weight, around 1,700.
Just the 5 sugars.
Essentially, yes. Because it's so short, it can bind antithrombin and cause that shape change to selectively inhibit factor Xi, but it's too short to bridge antithrombin to thrombin at all.
So purely an anti-factor Xi drug.
Exactly. Indirectly, via antithrombin,
Yeah.
but only targeting Xi.
And how does it behave in the body?
It has excellent, almost 100% bioavailability after subcutaneous injection. Doesn't bind to those other cells or proteins, so its effect is very predictable. Dose-independent clearance. And it has a long half-life, about 17 hours.
Wow, 17 hours. Allows for once daily dosing.
Yes, subcutaneous once daily. It's cleared entirely by the kidneys, unchanged. So it's contraindicated if creatinine clearance is less than 30 in LMN because it would just build up.
And dosing is straightforward, fixed doses.
Generally fixed doses for VTE prophylaxis and treatment, though the treatment dose might be weight-tiered. VK 5 milligrams of 7.5 milligrams or 10 milligrams daily based on weight. Studies show it's effective, similar to LMWH, with comparable bleeding rates.
Side effects, HIT risk.
HIT seems to be extremely rare with Fondaparinux, and crucially, there's no cross-reactivity with HIT antibodies. So it can be an option for treating patients with HIT, although direct thrombin inhibitors are often preferred based on more data.
Bleeding risk, and is there an antidote?
Bleeding is the main risk, like the others, but unfortunately there's no specific antidote. Protamine doesn't bind to it at all. There's some suggestion that recombinant activated factor A, might help in severe bleeding, but it's not a proven reversal agent.
Okay, that covers the indirect inhibitors. What about parenteral direct thrombin inhibitors, Argatroban and Bivalirudin?
Right, these work differently. They don't need antithrombin. They bind directly to thrombin itself and block its active site.
A more direct hit on thrombin. Let's take Argatroban first.
Argatroban is a small molecule direct thrombin inhibitor. It's metabolized primarily by the liver, so you need caution in patients with liver impairment. But it's not cleared by the kidneys, which can be useful, for example, in HIT patients who often have kidney issues too.
How's it given and monitored?
Continuous the infusion. And its effect is monitored using the APTT, similar to heparin, but the target range might be slightly different. A key thing with Argatroban is that it also artificially elevates the INR.
The tests used for warfarin.
Exactly.
Yeah.
Which makes transitioning a patient from Argatroban to warfarin a bit complicated. You might need to measure factor X levels to guide warfarin dosing during the overlap, or stop the Argatroban briefly before checking the INR.
Right. And Bivalirudin.
Bivalirudin is a synthetic peptide based on hirudin, the anticoagulant found in leech saliva. It binds thrombin at 2 sites, the active site, and another site called exosite 1.
Leech saliva. Does it work differently?
It has a very short half-life, the shortest of this group, maybe 25 minutes. It's broken down by enzymes in the blood and also partly cleared by the kidneys. It's often used during PCI, percutaneous coronary interventions, like stenting.
Why then specifically?
Its short half-life is advantageous there. Effects wear off quickly when stopped. It's monitored with ACT at high doses, like in the cath lab, or APTT at lower doses. Some studies suggested less bleeding compared to heparin in PCI settings, which made it popular, especially as an alternative for patients with HIT undergoing PCI.
Okay, that's a good tour of the parenteral options. Let's switch to the pills, the oral anticoagulants. Warfarin has been the standard for ages, hasn't it?
For decades, yes. Warfarin is a vitamin K antagonist. It works completely differently from the drugs we've discussed so far.
How does it antagonize vitamin K?
It inhibits an enzyme called vitamin K epoxide reductase complex 1, or VKORC1. This enzyme is essential for recycling vitamin K in the liver so it can be reused. Vitamin K is needed by the liver to add a final chemical group to several clotting factors, factors 2, prothrombin, ZX, and X, to make them fully functional.
So it stops the vitamin K recycling, meaning the liver can't make proper clotting factor.
Exactly. It also affects the natural anticoagulant protein C and S, which also need vitamin K. Without sufficient active vitamin K, the liver produces factors that are, well, duds. They don't work properly in the coagulation cascade.
And this takes time, right? That's why it has a delayed onset.
Precisely. You have to wait for the body to clear out the existing functional clotting factors that were made before the warfarin started working. Factor 7 has the shortest half-life, about 6 hours, but prothrombin, factor 2, has a long half-life, around 60, 72 hours.
So it takes days to get the full effect, which is why you need that overlap with heparin or LMWH when starting treatment for a clot.
Absolutely. You need that faster-acting injectable anticoagulant to provide cover for usually at least 5 days. And until the warfarin effect, measured by the INR, reaches the desired therapeutic level on 2 consecutive checks.
Ah, the INR, International Normalized Ratio. Monitoring is a huge part of warfarin therapy, isn't it?
It's essential. Warfarin has what we call a narrow therapeutic window. Too little effect, low INR, and the patient is at risk of clotting. Too much effect, high INR, and the risk of bleeding goes way up.
And lots of things can affect the INR.
So many things. Diet is a big one, specifically the amount of vitamin K in the diet, mostly from leafy green vegetables. Lots of other medications can interact, either increasing or decreasing warfarin's effect. Illness can affect it. And there are genetic variations, too, particularly in the VKO or C1 enzyme it targets, and in CYP2C9, the main liver enzyme that metabolizes warfarin.
Wow. So the right dose for one person could be totally wrong for another.
Exactly. Which is why frequent INR monitoring is non-negotiable. The usual target range for most conditions, like VTE or atrial fibrillation, is an INR of 2.0 to 3.0. For some higher-risk situations, like mechanical mitral valves, the target might be higher, maybe 2.5 to 3.5.
How is it dosed initially?
Usually start with maybe 5 milligrams daily, sometimes lower in elderly or higher-risk patients. Check the INR after a couple of doses, and then adjust based on algorithms or clinical judgment. Once stable, monitoring might stretch out to every 4 weeks or so, but any change in health, diet, or medications often requires more frequent checks.
What about side effects besides bleeding? I've heard of skin necrosis.
Yes, warfarin-induced skin necrosis is a rare but serious complication. It typically happens early, within the first few days of starting therapy.
Yeah.
It's thought to be related to warfarin causing a rapid drop in protein C levels. Remember, that's a natural anticoagulant that also depends on vitamin K.
So you get a temporary proclotting state in small blood vessels.
That's the theory, yes. Especially if someone has an underlying, maybe undiagnosed, protein C or S deficiency. It causes clots in the tiny vessels of the skin and subcutaneous fat, leading to tissue death. Treatment involves stopping warfarin immediately, giving vitamin K, and starting heparin or LMWH. And warfarin in pregnancy, definitely a no-go. Absolutely contraindicated, especially in the first trimester. It crosses the placenta and can cause serious fetal abnormalities, warfarin embryopathy, and bleeding. Heparin, LMWH, or sometimes Fondaparinux are the preferred anticoagulants during pregnancy. However, warfarin is considered safe during breastfeeding as very little gets into breast milk.
And if serious bleeding occurs on warfarin, how is that reversed?
You stop the warfarin, obviously. For rapid reversal, you can give vitamin K intravenously, slowly to avoid reactions. But vitamin K takes hours to start working as the liver needs to synthesize new factors. For immediate reversal, especially in life-threatening bleeding, the treatment of choice is a 4-factor prothrombin complex concentrate, or 4-FSPCC.
PC, what's that?
It's a product derived from human plasma that contains concentrated amounts of the vitamin K-dependent clotting factors, 2, 7, 9, and X. Giving PCC rapidly replenishes these factors, bypassing warfarin's effect. Fresh frozen plasma, FFP, used to be used, but PCC is faster, lower volume, and more effective.
Okay, warfarin effective but complex to manage. Now, the newer kids on the block, the direct oral anticoagulants, or DOACs, how do they compare?
DOACs, sometimes previously called NOACs, novel oral anticoagulants, have really changed the landscape in the last 10-15 years. They offer several key advantages over warfarin for many patients.
Like what? What makes them different?
Well, first, their mechanism is more targeted. They directly inhibit either thrombin, factor DI, or factor SAN. Dabigatran is the direct thrombin inhibitor, Rivaroxaban, apixaban, and edoxaban are the direct factor XAN inhibitors.
So one specific target enzyme, unlike warfarin, affecting multiple factors.
Exactly. This leads to a much more predictable dose-response relationship. They have a relatively rapid onset of action hours, not days like warfarin,
Hmm.
and generally shorter half-lives.
And the big one, monitoring.
For most patients and indications, routine coagulation monitoring, like the INR, is not required with DOACs. They're typically given in fixed doses, maybe once or twice daily, depending on the drug and the reason for using it.
That sounds hugely more convenient.
It's a massive advantage in terms of convenience and potentially adherence, no regular blood tests, no constant dose adjustments due to diet or minor interactions.
What are they typically used for?
Their main indications are stroke prevention and non-valvular atrial fibrillation, that's a big one, and treatment and secondary prevention of VTE, DVTPE. Some are also approved for VTE prophylaxis after hip or knee replacement surgery. And low-dose rivaroxaban combined with aspirin is used for secondary prevention in some patients with chronic coronary or peripheral artery disease.
So no routine monitoring, but can you check levels if you need to? Like if someone is bleeding or needs urgent surgery?
Yes, you can. While not routine, specific quantitative assays that measure the drug concentration or anti-NAGDOX activity for the AXOX inhibitors are available in many hospital labs now. These can be very helpful in specific situations: suspected overdose, major bleeding, preoperative assessment if the drug wasn't stopped appropriately, checking adherence if there's doubt, or in patients with renal impairment or extremes of weight where accumulation might be a concern.
Do standard tests like PT or APTT tell you anything?
They can be affected, but the degree varies depending on the DOAC and the test reagents. For example, the APTT is somewhat sensitive to dabigatran, and the PT, prothrombin time, which the INR is derived from, is somewhat sensitive to rivaroxaban and edoxaban. Apixaban tends to affect both less reliably. So a normal PT-TD doesn't rule out significant DOAC levels, and prolonged tests don't always correlate perfectly with the drug level or bleeding risk. The specific assays are much better if available.
Okay. What about side effects? Still mainly bleeding.
Bleeding is still the primary concern, yes. Overall rates of major bleeding seem comparable to, or perhaps slightly lower than, warfarin in large trials, particularly the risk of devastating intracranial hemorrhage, which appears consistently lower with DOACs.
That's a major plus. Any other bleeding patterns?
Some studies suggested a potential increase in gastrointestinal bleeding with some DOACs, particularly dabigatran and rivaroxaban, compared to warfarin, although this isn't seen universally across all studies and populations. Dabigatran also has a unique side effect of dyspepsia or heartburn in some patients, likely related to its formulation.
And pregnancy breastfeeding, same as warfarin.
Generally, yes. DOACs are not recommended during pregnancy or breastfeeding due to lack of sufficient safety data and potential fetal infant exposure.
Now, the crucial question, reversal agents. If someone on a DOAC has major bleeding, what can be done? You can't use vitamin K or PCC as effectively, right?
That was a major concern initially, but thankfully specific reversal agents have been developed. For dabigatran, there's idarucizumab, Praxbind. It's a monoclonal antibody fragment that binds dabigatran with extremely high affinity, instantly neutralizing it.
Wow, a targeted antibody.
Yes, very specific. For the factor XAN inhibitors, rivaroxaban, apixaban, edoxaban, there's andexanet alpha, Andexa. It's essentially a modified inactive form of factor A that acts as a decoy, binding up the drug molecules so they can't inhibit the real factor A.
So specific antidotes exist now. Are they readily available?
Idarucizumab is generally quite available. Andexanet alpha is becoming more available, but is significantly more expensive, and its use might be restricted by hospital protocols. Dosing for andexanet also depends on which antigen inhibitor the patient took, the dose, and when they took it.
And if these specific agents aren't available or appropriate?
Then 4-factor PCC, like Kcentra, is generally recommended as the next best option, although its effectiveness for reversing DOACs isn't as definitively proven as it is for warfarin. Supportive care, stopping the drug, fluids, transfusions, managing the bleeding source remains paramount.
Okay, good to know reversal strategies exist. Lastly, what about managing these drugs around surgery? Perioperative management.
That's a really common and important scenario. For warfarin, as we touched on, it's usually stopped about 5 days beforehand to allow the INR to normalize, typically aiming for 1.5. Bridging with heparin or LMWH might be used in high-risk patients, but increasingly studies suggest it might not be needed for many, like those with AFib, and might even increase bleeding risk.
So less bridging than before.
Potentially, yes, based on recent evidence, but it's still crucial for very high-risk patients like those with mechanical heart valves.
Hmm.
Warfarin is usually restarted post-op when bleeding risk allows. If urgent surgery is needed on warfarin, reversal with PCC and vitamin K is the way to go.
And for DOACs before surgery.
Because they have shorter half-lives, they need to be stopped much closer to the procedure. The exact timing depends on the specific DOAC, the patient's kidney function, since renal clearance affects half-life, and the bleeding risk of the planned surgery.
So maybe just a day or two beforehand?
Often, yes. For low bleeding risk procedures, maybe stopping 24 hours before or skipping just 1 or 2 doses. For high bleeding risk procedures or in patients with kidney impairment, it might be 48 hours or even longer. There are specific guidelines and protocols for this.
And restarting after surgery?
Usually, prophylactic dose LMWH is given initially post-op until the surgical bleeding risk settles. Then the DOAC can be restarted, often 24-72 hours after the procedure. Interestingly, for some procedures like pacemaker insertions or even catheter ablations for AFib, studies have shown it can be safe to continue the DOAC without interruption, perhaps just holding the morning dose on the day.
So it really requires careful planning and coordination.
Absolutely. It's a constant balancing act between thrombosis risk and bleeding risk, tailored to the individual patient, the drug they're on, and the procedure they're having. And this field keeps evolving. Research is ongoing to develop anticoagulants that are even safer, maybe targeting different factors like factor Azi or 12, potentially offering good anticoagulation with even less bleeding risk.
Fascinating stuff. Okay, let's try and wrap this up. We've covered a huge amount today.
We really have.
From the basic differences in how clots form in arteries versus veins, right through to the nitty-gritty of heparin, LMWH, Fondaparinux, warfarin, and the DOACs, how they work, how they're monitored or not, managing bleeding, handling surgery. It's a lot.
I think the key things to take away are just how diverse the options are now. Each drug class, even individual drugs within a class, has its own mechanism, its own pros and cons. And choosing the right one, managing it properly, is incredibly personalized.
Yeah, it depends so much on the patient, their specific condition, their risk factors for both clotting and bleeding, their kidney function, other meds. It's complex.
It really underscores that this isn't just about thinning the blood. It's about precisely modulating a very complex biological system.
So hopefully this deep dive is giving you a much clearer picture of this whole world of anticoagulation. It's definitely more intricate than maybe it first appears. It's this constant balancing act.
And the progress continues, which is exciting. It offers real hope for better prevention and treatment of really serious conditions like stroke, heart attack, DVT, and PE. But of course, this conversation is for understanding. Always talk to your healthcare professional for actual medical advice.
Absolutely. Which kind of leads to a final thought, perhaps. As we get better and better at understanding coagulation and develop these ever more targeted drugs and reversal agents, how close are we, do you think, to truly personalized anticoagulant therapy, where we can perfectly match the drug, the dose, the duration to each individual's unique risk profile, maximizing protection while truly minimizing bleeding?
That's the ultimate goal, isn't it? We're making strides with genetic testing for warfarin sensitivity, understanding drug interactions better, developing specific antidotes, but getting that balance perfectly right for every single person. That's the challenge and the exciting frontier for the future in this field. Lots more to uncover.